So this lecture was supposed to happen 2 weeks ago, so that's why it's kind of out of place. We did all these cool lectures about starting intern year and residency, and then there's this 15-minute talk about Fasicular blocks.
Which is useful.
It's useful, it's useful. I'm hearing from the audience that you're getting confirmation that it is useful, so might as well pay attention. Special thanks to the small talks team, especially Dr. Matt Turner, Dr. Kendall, Dr. Scarafali, our education chief, and Dr. D'Souza, especially catching multiple spelling errors that I had.
Yeah, just bring it to yours. And then click yours.
Okay. Gotcha. So the things we're going to go over are the EKG features of all the Fasicular blocks, as well as like all the combinations thereof, left anterior, left posterior, bifasicular and trifasicular blocks. The reason why I chose this topic is because typically I'll see an EKG like this and be like, this looks normal, but hopefully this lecture will help us take it one step further, or something like this. And especially when I started intern year, I would just look at it and be like, this is wacky. But hopefully this will help us describe some of that wackiness. So the first question, whenever you're looking at an EKG to help determine if there is any of these blocks, is if there's any axis deviation. And the reason why that is, if you see, this is a diagram from Martingale's EKG book with the fascicles. So you have your AD node, and then your hysterconjugate system, which is these guys, your right bundle, and then your left ones go to the left posterior and the left anterior. So you can see that if there's, this one is an illustration demonstrating left anterior block, but you can see that if there's a delay or a blockage in these electrical systems, you're going to have a change in your axis. In this case, if you have a block here, it's going to be more towards your left. If you have a block here, your axis goes more towards the right. So those of you that were in medical school more recently probably remember this pretty well, actually, determining the axis. So I'm going to go through just really quickly the reason why we look at the limb leads and 1, 2, 3 to determine axis, and just kind of a quick and easy way to determine axes. So this is my very beautiful illustration of a patient and the axes. So your normal axis is between -30 here and +90. Up here we have left axis deviation, we have extreme axis deviation here, and this is right axis deviation. We all know when putting on the EKG leads that you've got your right arm, your left, and your foot, and the direction for these axes makes sense. Just the vector for the right arm goes towards the right arm, and so on and so forth. And just remembering from the physics classes we all had to take as pre-med, that vectors are just straight electrical lines, like straight lines that are direction that electricity is going. So the squiggles on your EKG are just showing that a positive vector makes a more positive deflection or more positive squiggle, and then your negative squiggles that go like below the baseline are vectors that are going away from the lead that it's measuring. So this actually took me a really embarrassing amount of time to understand in medical school. Is that lead 1, like why does it correspond to this? So I'm just going to go through these other leads really quickly, the limb leads that are derived from ABR, ABL, and ADF. So lead 1 is from right to left. So because the vector is in this direction, the vector transposes to our little unit circle type thing right here to about 0 degrees. That's a lot of things, but basically, and then 2, because it goes in this direction, it transposes to here, and you can see why 2 is used as the rhythm lead, whatever that is, the one you look to figure out like the rate and stuff, because in a normal axis, your left ventricle is in this direction, so you're going to have the biggest QRSs, the best ability to see P waves, and so forth in that lead. And then finally, your lead 3, which goes this way towards the right axis. And I just have this illustration as a way to show that even in this made-up EKG, where they isolated just the QRSs in the limb lead, you can tell what axis this made-up EKG should be in. So first of all, it's either really positive, you have positive vectors going towards ADF, positive vector going towards 2. So that's in this direction. So you have a positive vector going towards ADF and towards 2, and you're all positive in 2, so definitely going towards 2. And then you're very negative in ABR, so it's a vector that's going opposite of ABR. So that's ABR is this direction, so opposite of that is this way. This arrow kind of gives away the answer, obviously, but just follow along with this. And then you can also look at the most isoelectric lead, which in this case it's like 100% isoelectric because it's a made up EKG ABL. And based on how physics works, I don't remember how to explain why the physics works this way, but since how physics works, so if this is the most isoelectric lead, then that's the most, then you're going to be somewhere perpendicular to this lead. So this is ABL, isoelectric. So the vector is going to be perpendicular in some way, either this way towards like the negative 120 or this way towards that positive 60. And you already know based on these other leads that you're going toward this direction. So that's another way that you can determine that this is a normal axis. And then we can just go through this one as well. So in this EKG, you see you're again very positive in 2, positive in ADF. This is 2, this is 3 ADF. So you're going in this direction. So you can be either in this normal axis or this right axis. And to take it a step further, you can look at the most isoelectric lead. So going through this one, 1. So this is 1. So it's either this way or this way. You already know it's going to be in this direction. So that doesn't give you that much information. Still could be maybe normal, maybe this is borderline. But if you look at this again in 1, it's isoelectric-ish, but it's more negative. So that means the electrical vector, the main electrical vector is going to be going a little bit away from 1. So you can think of this as like a clock hand that's turning away from 1. So you're perpendicular and you're going in this direction, but you're a little bit away. So you turn a little bit away. So this actually gives you right axis deviation in this EKG. Right. So moving on, these are the criteria for a left anterior fasicular block. You need left axis deviation. There's certain QRS methodologies that are part of the criteria, which we'll go through. It'll make more sense visually than it does just looking at the list. You have a normal QRS, and we'll also show an example of what this RV peak time means. When initially reading through this and trying to make this lecture, I'd always get mixed up which are the criteria for a left anterior fasicular block versus a left posterior fasicular block, because they're very similar. They're essentially opposites, but sound the same when you are reading about it or even looking at an EKG. So what I remembered is that in the LAFB, you have LAD, just have LA in common, and then the left posterior is the one that doesn't have LA in it. So just remember one, and then the other one will make sense. So these are those morphologies in the QRSs. It's basically the shape of the QRS in certain leads. And this makes sense intuitively because if you think about the electrical vectors, like we talked about with the axes and the shape of the QRS, then if you have a delay or a block in the left anterior fascicle, that's the fascicle that's essentially going this direction. So here, it's the fascicle that's going this direction towards 2 and towards 1 this way, towards the normal axis. So if you have a delay or a block here, then in 1 and EBL, which are the leads that measure electrical vectors going this direction, you're usually going to have a deflection this way, a little bit away, like you're going down the road, you're like, this is the fastest way to get here. You're going, and then there's a roadblock. So then you have to take a detour and turn back around and go this way. So initially a negative deflection away, and then can't go any further. So then the electrical vector goes the other way, and so you have a more positive deflection. And then it's essentially the same but opposite in the inferior leads in these guys, because you're initially going to have an electrical vector that goes towards these leads. So towards always makes a positive deflection. So you go towards it, and then you're like, there's a flood in the road, have to turn back around. And then you go away, and away is negative in the inferior leads.
Just a heads up, if we do have some issues, we can turn away from the mic hearing you. So if you can just
stop turning. Okay. What if I go like this? Okay. Cool. Okay, so this is that illustration of what a prolonged ROA peak time is. The criteria is just over 45 milliseconds. 40 milliseconds is a tiny box in the EKG, so it's just somewhat over that much from the beginning to the peak. This isn't quite as important, but this is just an illustration to demonstrate what that is. And again, these are the morphologies you're seeing in the QRSs. We can go through this EKG real quick. This is the one that I showed in the beginning. That's like basically just normal sinus rhythm. So you see the rate's about 100. We counted out maybe like 300, 150, 100. And then there is a P wave for every QRS. And all those P waves are less than 1 big box. So you don't have an AB block. This is the normal interval. QRSs are narrow in the normal range. Next, we can look for access. So looking at these QRS morphologies, there's some that are really isoelectric. We can see that you're very negative going away from all of the inferior leads, and you're very positive in these high lateral leads. So that gives us left axis deviation. And then next, do you have those QRS morphologies that match? So because you have left axis deviation, this might be a left anterior fasicular block. So the next step is to see if you have a morphology that can match those blocks. And in fact, you do. You can see that you go a little bit positive at first in the inferior leads and then negative in all these inferior leads, and then the opposite in the bilateral leads, where you go initially a little bit away from these bilateral leads and then a big positive reflection towards the leads. So next we'll talk about the left posterior fasicular blocks. These are the criteria for these is essentially the opposite of the left anterior fasicular block, with one caveat, and that caveat is that these are a lot more rare. So you have to first rule out a better reason for there to be a right axis deviation, like a PE, really severe COPD, pulmonary hypertension, for example. The reason why these are a lot less common is because this fascicle receives blood supply from both the LAD and the PDA, whereas the left anterior fascicle receives blood supply isolated from the LAD. So left anterior fascicle blocks are pretty common, but a left posterior fasicular block by itself, isolated, is extremely uncommon, and they're actually more likely to be seen in combination with a right frontal branch block forming a bipasicular block. So again, I'm just going to go through one of these because it's essentially the opposite of earlier. So since your block or your delay is here, you're going to have morphologies that go along with that. So I'm just going to go through the inferior lead findings. So the inferior leads, you initially have a deflection away, like this direction. So you're going a little bit away, and then there's a roadblock here now. So so then the electrical signal goes down the next quick pathway, which is the left anterior fascicle. So you have a bigger deflection towards these inferior leads. And again, and there's a delay as well, but this time it's in ABF instead of ABL. These are the morphologies. And even though I read these and I was like, oh, that makes sense intuitively based on how electricity works, it's still confusing because it's very similar to the left anterior fasicular blocks. So to figure out which one is which when you're looking at an EKG, there's a mnemonic that I read about that lots of people share in your videos, where if you look at the inferior leads in isolation, if you just consider the inferior leads, you can think of the left anterior fasicular blocks as anterior being more in the front or more forward. So if you're looking just at the inferior leads, you can use the mnemonic that because the anterior blocks are more in the forefront, you first have the positive deflection, and then the negative deflection. So first positive and then negative, and then in your left posterior fasicular blocks, because posterior is more in the back, in the inferior leads, you can just remember that it first goes down and then up. And you'll see in real EKGs, sometimes this is a lot more subtle, but this just helps to differentiate these morphologies that are really easy to get mixed up. And again, this is just to remind us that in order to diagnose the left posterior block in isolation, you have to first rule out these other causes that are sometimes more likely than just the left posterior fasicular block in isolation. So next, I'm going to discuss really quickly what a bipasicular block is. It is what it sounds like. It's basically a block in two of these frequency fascicles. The most common would be a right bundle plus a left anterior fasicular, just because the left anterior fasicular is the most common. This actually occurs in about 5 to 7% of anterior MIs, according to the Martindale book. And but you can also see these kind of pathologies in other clinical situations, such as hyperkalemia, electrodynamic abnormalities, and again, you have to think about these patients that have this kind of disease could have more severe ischemia than someone who does not, and especially if you're seeing somebody that's progressing from an isolated fascicular block to then having a bipasicular block in the next EKG, they could be having progressing ischemic disease. The least common is the right bundle plus a left posterior fascicular block together. And because this demonstrates that there might be disease in both the PDA and the LAD, these are the most serious. So a patient like this that's symptomatic, I consider admitting them for further monitoring workup and potentially even a pacemaker, a pacemaker, because they can actually progress to complete heart block, to a complete AV block. And then this one, the left posterior and the left anterior together, clinically, they're basically similar to a left bundle branch block. There are ways to tell this apart on an EKG, but we're not going to go into that today. So finally, your trifascicular block. This sounds like it sucks because you have disease in all three fascicles of some sort. Not necessarily just the fascicles though. Dr. D'Souza pointed out that we're moving towards the language of calling these advanced AV blocks because part of the criteria is also having disease in the AV node or some kind of AV block that goes along with this. And in these patients, they, at the very least, if they're asymptomatic, all need a cardiology referral to see them as an outpatient for electrophysiology studies. And if they're symptomatic with syncope, lightheadedness, any symptomatic bradycardia, they would actually need admission to a monitored setting, preferably the CCU, because they are very high risk of progressing to a complete AV block and need to have a pacemaker placed. So we can go through this EKG systematically. So going through the rate, 1, 2, 3, 4, 5, 6, 7, 8. So about 60 for the rate. You do have a P wave before the QRS is here, but it is widened because you can see this is larger than one of the big blocks. You have first degree AV block, there's no drop QRSs, but you have a widened PR ventricle. Next, let's look for the axis. So again, we have left axis deviation here, very negative in these inferior leads, very positive in these high lateral leads. You also have a right bundle. I'm not going to go through the criteria because I'll run out of time, but you have a right bundle branch block here. You can see the RSR prime morphology and these prolonged third upward S waves. And then you do have the morphology for a left anterior fascicular block. You have initially in the inferior leads, you're initially going up a little bit and then down, initially up and then down. So this is the RS morphology. So you have all three of these things, an AV block, a right bundle branch block, and a left anterior fascicular block. So this EKG looks kind of wacky, and it is wacky. There's something like going on. It is a trifascicular block. So the most common of these are actually incomplete blocks, which could mean either there's fixed block in 2 of the fascicles and then an AV block, or sign of some kind of AV block, whether that's first degree or second degree, or fixed block in 1 fascicle and then some alternating signs of a block when you repeat the EKG. Sometimes when you repeat an EKG and the axis is different, you could think it's just lead placement or something like that. But a symptomatic patient, you should definitely consider that this could be a patient that's having evolving ischemic disease and evolving disease to the conduction system. And there's also what's called a complete, or considered a complete block. Part of this criteria is having a 3rd degree AV block. So I think in most of these patients, you would first recognize this part and be treating them for that. And then maybe later put on our thinking hats, but I wonder if there's a trifascicular block. And then you can like look for that. So let's go through just a few of these EKGs that are a little wacky. So this one, you see that there's some irregularity. Looks like there may be dropped QRS here. So for the most part, there's a P wave before the QRS looks like sinus C, but there's this drop QRS here. And you see here that the PR intervals do widen. So I call this a Movitz type 1, where it widens before the drop QRSs. And then looking up here, you determine the axis. So you're very negative again in these inferior leads, positive in the high lateral leads. You're having some left axis deviation here. Again, this one is the partial right bundle. It's a little bit harder to see, but it's taking over for it. And then you do have that morphology that matches the left anterior fasicular block. So you've got your Mobitz type 1, your left anterior fascicle block, and your right bundle. So this counts as the trifasicular block. We can go through this one. These QRSs look a little bit more wacky, but you have a rate of, this one's about 60. You do have P waves for the QRSs, but it is, you can tell like here that it is widened, a widened PR interval, so that would be a first degree AV block. It's a little bit more subtle to look at the axis on these because the QRSs aren't as typical, they aren't as like nice and well defined. But you can tell that these are more negative overall. There's more space under the curve and over the curve in the inferior lead, and vice versa in the lateral leads. So you do have a left axis deviation, and even though it's more subtle because of the weird looking fluoresces, you do have that RS morphology in the inferior leads, the first up and then down. So this is another example of a left anterior fasicular block, example of first degree AV block, and you have a right bundle branch block here as well. It's a little bit more subtle, the RSI primes here, but it does fulfill the criteria. So again, another fasicular block. And then this one, I think any of us looking at it would be like, this is good. You can already tell the rate's really, really slow. So this 1, 2, 3, 4, 5 times 6, so that's 30. Not good. You can already tell that the P waves, you do have them, but are they hitting the QRSs? No, not really. So you already have a 30-degree AV block. This is already somebody who's putting pads on, getting out some atropine, some epi, getting dopamine ready just in case. Thinking about transcutaneous pacing if needed, or even a transvenous pacer. So after you get this patient stabilized, for example, then you can go back and be like, hey, what else is going on in EKG? They also have the right bundle, and it's hard to tell because the QRS doesn't really show up here, but they do also have left axis deviation, and they fit the criteria for a left anterior fasicular block. It's just a little bit more subtle because of the weird QRSs. And another thing I want to mention about these patients is that the reason why sometimes you try to give atropine to patients that are bradycardic and it doesn't work very well is because atropine affects the AV node and reduces vagal tone on the AV node. And in patients that have fasicular blocks, that block where that delay is actually past the AV node in the hysterEKG system. So it would make sense that some patients don't respond well to atropine and they need to go on to electricity or other methods to keep their rate up. So this is a review of the clinical significance of trifasicular blocks. Patients that are symptomatic, especially syncope and headedness, they need to come in to monitored setting. They'll need a pacemaker. If they're asymptomatic, it's just the incidental finding. They can follow up as an outpatient and get ET studies. And just remember that there's other things, molecular abnormalities, toxicities that can cause this kind of pattern. So in summary, this is like a pretty loaded slide. It's just a cool little like card that I found online that I think is helpful to go through to review these things. It is a lot of random squiggles and things to remember, but basically you have the basics basically add up. Remembering your axes, being able to look at a QRS morphology and determining why that is the way it is and why that could be important, and the important clinical reasons why we look for trifasicular blocks and why they can be important to a patient, especially when they're present with syncope or lightheadedness or other cardiac complaints. These are my sources and a very cute cat. Any questions or comments?
I think like how you highlighted focusing on the conduction and just instead of memorizing like the funny or R prime, just focusing on like where the conduction is delayed, and that's going to be your positive vector on your EKG is super important and helpful versus just memorizing.
So for those at home, Sophia, just mentioning that She finds it helpful also to focus on the conduction, remembering where that comes from in an EKG rather than just remembering mnemonics like what's an RSR and a QR and RS. And I agree because like going through this, at first I was like, what the heck, I'm never going to remember this, but then going back to the basics really helped. I don't know how to open the chat.
Oh, Trevor said right axis deviation, and he said awesome.
Oh, okay. I'm not sure what that means, but okay. All right. Dr.
For your incomplete trifasicular blocks, there's no like change in like the fascicle between left anterior and left posterior. Are those pretty stable? Like it's like a pretty low percentage that they go into like heart block.
Yeah, it is. Yeah, you're right. It is a pretty low percentage. I think less than 4 in a year, or maybe less than 1 in a year.
So then basically, as long as they don't have like syncope or some sort of associated symptoms, they can follow outpatient.
Yeah, exactly. So what Subham was saying is that patients that have the trifasicular block where you're alternating between the left anterior fascicular block or the left posterior fascicular block when you repeat the EKG, actually a very small percentage of those go on to develop a complete AV block. So if they're asymptomatic, they can follow up cardiology and outpatient, and that's safe, even though their EKG looks wacky. And then Dr. G.
Yeah, a few things. One book that I like a lot, I like the Martindale book, and I like Dr. Martindale, but one book that I found very useful for beginners is The Interpretation of the 12-Lead EKG by Tomas Garcia. Very nice explanations and pictures and everything. So yeah, that's a good book to look at, and it's paperback. It's not very expensive. And they cover this pretty well. He covers this, Tomas. The other thing that I was going to say is very useful for me has been that if I find a bifascicular or trifascicular block, either of those, I especially look for them in syncope patients. Because if you see a syncope patient, and even though now they're still in sinus rhythm, but you see they have a bi or trifascicular, there's a good chance they went into complete heart block or Mobius type 2, probably complete heart block. And you definitely want to keep those people. And the third thing, just one thing that helps me look very quickly for possible blocks, the more common ones, is I look at 1 and F. And you said this, and I just want to emphasize for me, if I find that lead F is more down than lead 1 is up, that almost always is going to be a left anterior fascicular block. And that which is the most common of that. And then I look at for a right bundle. If there's a right bundle with that, which again, there can be other types of block, but that gives me bifascicular, like you said. And then I look for the PR, and if I have a first degree with that big left axis and with the right bundle, then that's trifascicular. Those are the, and you mentioned that, and that's the most common and the most easy to remember, I find, for me.
So Dr. G had a few points he wanted to make. So the first, I'm going to go backwards. So one thing he said is that one way he looks at EKGs is to see if ABF, right, is lower than, what's the one that would be higher?
They heard all that.
Oh, you heard all that? Okay, cool. Never mind. Thank you, Dr. G.
So